No, you do not have that effect. Lose this one, you're fired.
It's the chair. I understand.
The Finance Committee will please come to order.
Everybody behaves well, too.
I know everybody follows me right along, don't they? Yeah. All right, so any citizens wishing to address the committee this morning? None signed in. All right, so let's move on to item 3. I command the room, don't I? Item 3 is approval of the minutes from the February 28th meeting. I'll entertain a motion. We have a motion by Mr. Wynn, a second by Mr. Bose. Any questions on that? All in favor, please say aye. Opposed, motion passes. The CEO report, Ms. Clark.
Good morning. How are you? I got promoted, Robert. I didn't know if you heard that, but I was excited.
I'm not sure that that's a promotion or not, but best of luck
I
to
don't know
you.
if I want the job.
We're all aspirational this
Now,
morning.
before Sharon starts, we need to make a note that her son Aaron got to the state championship for a geography contest, and I can't tell you which is further east or west, Nebraska or Kansas, and this kid's naming rivers in Iran.
Wow.
And it was really, really cool. So he made it, and no disrespect to anybody in this room, but I think he could beat every one of
Oh,
those.
no question.
So
Congratulations.
congratulations to him,
Yeah,
and he needs to
thank
know
you.
that.
Thank you.
Just don't let him
We
go to
are
A&M.
nerds in 2 different ways. What was that about? A&M?
Nothing.
He's already been accepted. What are you talking about?
So he is going to A&M?
He thinks he is. You know, hopefully the university will agree in about 5 years, but we'll see. Yeah.
Yeah, maybe he'll get into a real school.
Okay.
Just don't suggest he be on the crewing team for UT, and we'll be in good shape.
No one's doing
Yeah,
any
I
bribes
hear
to get into
crazy
A&M.
stories about
Yeah.
crew members.
No one's bribing anybody to get into A&M, though,
Mr.
right?
Chairman, you've lost total
Okay,
control.
I have.
this has
You
gone
lost-
bad.
yeah,
I never had control. Are you kidding? Ms. Clark, would you like to give us the CFO report this morning?
I am qualified to do so.
Thank you.
Actually, today, I'm excited to introduce Courtney Bodecker. If you just want to stand up, I'm not going to make her come sit at the table today. But she is our new controller. This is her second week here. So next month, I will be able to introduce another new team member. We have a senior vice president for finance starting next week. So I'll introduce her, but Courtney has 14 years specifically in healthcare. She's been local. She's worked at Cook Children's as well as most recently Texas Healthcare. So we are really excited to have her come and her experience.
Great.
So,
Welcome, Courtney.
thank you. And then we have the February financial statements. February was a great month, so, you know, even though our inpatient volumes were slightly down, and I'm on page 12, from an inpatient standpoint, we did have about 3% lower admissions than budget, but as you'll see on the income statement, we were able to control our expenses as well. Patient days were up, and our CMI, which is the bottom left, measures our patient acuity on a Medicare scale, but our CMI was slightly higher than expected. From an outpatient standpoint, ER and urgent care visits were a little lower than budget. If you were looking at the trending graph, remember February is an unusual month in that it only has 28 days, so it looks like volumes were way down. But if you look at it on a per day, we actually had about 317 patients for, the red one. We have about 317 patients for the month each day. And if you looked at it year-to-date, we were averaging about 313. So it was a little above average month for the emergency department. And urgent care is very similar. We saw 139 a day in urgent care, and they've been averaging about 140 for the first 5 months. Primary care visits were only slightly under budget this month. You can see that they're building. And our specialty clinic visits continue to be higher. They were 8% higher than we had budgeted. You can see the trend there. Invasive lab, which is the top right corner, that continues to be a really strong service line. And then our surgical volume is continuing to trend a similar way. Again, looks like it went down, but this is a really short month compared to January. And our outpatient surgery visits were only about 4% below budget, but well above last year. Our psych statistics, you can see that all service lines were pretty on budget. Our patient days are, I've had some questions about the red, green, yellow boxes at the top corner of these charts. It doesn't necessarily mean it's negative or under budget, it's unfavorable. If it is yellow, it's within 3% of the budget plan. If it's greater than 3%, it's actually red. And anything favorable or on target is going to be the green box. So you can just kind of quickly see there's a lot of numbers and charts going on. So that's just a quick way. Our clinic visits continue to be significantly higher than last year. Again, we have made some changes to the way that patients are discharged from the psych emergency clinic. And you can see that those visits are slightly up as well. From a financial side, our days cash on hand is 251 for the end of February. That is what's available for operations, not to include the cash that we've set aside for the construction fund. And our total days cash on hand is about 301. We're continuing to see slight decreases in our AR days. That is about 51 days here. And what that tells us is on average, it takes us about 51 days to collect on an account from the data service. So
It's collecting from all payer sources.
it is. You know, Medicare, Medicaid typically pays us much quicker than a commercial plan. And that would also include any patient responsibility balances on those commercially insured or any self-pay.
And the uncollectibles we take out from that calculation, the ones we don't collect on.
Once they have gone through our final collection process. So we've got some accounts that can take us closer to 9-12 months to collect on. And then some we can get paid within a couple of weeks. So that's an overall average.
Oh, wow. So even the 9-month, 12 months ones are in that 51-day calculation.
Until we have deemed them uncollectible and they're returned from bad debt.
That's pretty good.
It is good. Yeah. There's a very wide range that makes that up. And we continue to be favorable on our FTEs per adjusted patient day. For those of you who may not have heard of an adjusted patient day, that is an industry calculation where we kind of merge together our inpatient and our outpatient volumes, which are not easily pushed together, and it's based on revenue dollars. But, and that tells us how many people that we actually paid and worked compared to budget. So we had budgeted to pay about 5.7 FTEs for every adjusted patient day, and we're actually working about 5.5. So our largest expense is salary and benefits. There's two components to that. There's going to be the hours that we pay versus the premium pay, and what it costs us to actually pay for those hours worked. So that's a really significant indicator of my salary expense. Here's our payer mix. I don't usually spend too much time on this, but we've got a couple of new board members. So this graph is actually based on generated charges. It's not based on what we collect, because if it were, that self-pay, the gray area that's up at the top, would be just a tiny, tiny sliver. So this is kind of heads through the door, and it shows us from the volume of total patient activity how these payer sources kind of turn out. So we've got about 22% Medicare in total from traditional and managed care, and then you have about the same 22% year-to-date for Medicaid. And then you see that our commercial plans here are about 15%. A lot of our commercial plans are high deductible ACA type plans, so even within that commercial bucket, you have a lot of uncollectible dollars often for people who have coverage, but it's catastrophic coverage. And then the self-pay and the connection are relatively the same population. They do not have any coverage, but the connection green pie chart are those that qualify for the program, and pretty much the three main qualifications that you have to meet is low income. They're usually about 138% of federal poverty guidelines. We also have, they have to reside within Tarrant County, and they have to be a citizen. And this pie chart, again, it's shown year to date, but it does not change significantly month to month. JPS connection enrollment, the part of the pie that we saw that was in the green, the 21%, these are actually qualified enrollees. We did have a nice increase of about 3% from January to February. So the income statement, again, we had a financially favorable month. We ended up about $900,000 ahead of a $380,000 budget. Again, volumes were down. We were about 3% under in patient service revenue, but we were able to control our operating expenses below. So we were almost $2 million ahead of our budget. Most of that savings is going to be in purchase service, supplies, and other operating expenses. There have been some projects that have been delayed, but again, some of those are going to catch up throughout the year, but we are 5 months in. If you look year to date, we're $5.3 million ahead of our budget, and that is very exciting. So we're holding strong. Each month we continue to add to that. Our low volume typically happens towards the end of our fiscal year, but we are in a very good position so far. This is hospital only. Yeah, we'll cover a claim, and then I also have kind of a consolidated financial picture for you. Are there any questions on the income statement from February? Okay.
Yes, sir.
I'm kind of trying to grasp this. At MedStar, we collect about 29% of our billables. And so we set a budget up, and then we decide what the charge of our ambulance is going to be to make us whole. Do you have that same problem here?
You know, from a hospital reimbursement standpoint, we don't have the luxury of going back and trying to kind of back into what we are going to charge. The way that the governmental payers pay us is set up on a historical, and we typically are paid on a DRG, and that's set and not negotiable.
We didn't have the luxury of backing into it either. It had to be forecast, and if we didn't make the forecast right, we obviously were on the wrong side of the ledger.
Right.
But we used historical data, sometimes I call it hysterical, but it was historical data, to determine what our budget for the upcoming year is going to be based on what our previous has been. I just wondered how much we're not getting paid that we've got to
So
recover
from my experience on a hospital side, your percentage charge does not really tell you a whole lot because hospitals charge very differently and have done so for decades. So one hospital might show a 20% collection rate, another hospital might show a 60% collection rate, but the one showing 20% of charge is actually collecting more money, dollars, than the one with a higher collection rate. So it's that denominator that is not consistent between facilities. For our budget process, we're going to be getting ready to kick that off in April. Once we have 6 months worth of information under our belt, we take about 3.5 months to try to forecast where we are. There are hundreds of departments that go into planning and creating volume budgets, creating the capital budget, and all of the expenses related. Volume is going to be what is most critical when we budget, and a lot of those are variable. So once we determine how many patient days we have, it's a historical calculation to see what our average salary expense to staff that is going to be. There's a medical supply component that makes up the majority of that 13 million. And there are some purchase services that are driven by volume, like in our medical records area. But a lot of the bottom side is driven by the volume projection. So I don't know if that answers your question.
It sounds like you've got about the same problem, but not the same magnitude.
Yeah, so it is a pretty complex process, but all of our net patient service revenue is fairly historical based on our collections. We do try to forecast changes that might be occurring with new physicians or new managed care contracts or new services that we might be providing, but those expenses are typically kind of a historical look with an inflation factor.
Thank you.
You bet.
Any other questions for Sharon on this, on the hospital piece? Let's go to a claim.
Okay, yes. So Acclaim had a very strong month from an encounter standpoint. This month, they were about 10% over budget, or over their plan, which is favorable. Year-to-date, they're running about 3% over their budget. So they're picking up quite a bit of speed. Again, February was budgeted to be kind of a lower month, but they had a very similar volume in February than they did in January. And then net operating expenses per encounter. This graph is important because it does show us, even with that 10% increase in visits, what are we spending on each visit, total expenses. That is right on for the first 5 months of the year. So on average, it costs us about $59 to provide one visit. Those are all combined. It could be a primary, it could be a specialty, could be an inpatient consult. So there's a hodgepodge of what goes into that denominator as well. This is the Acclaim provider pie chart. It looks really complicated, but each section is a specialty within Acclaim. And what we're trying to do is show you the employed physicians, any open positions that might be in that specialty area, and if there are contracted positions that are there. We do spend a lot of time at the board talking about how the provision of that care is done, and a claim represents all of those physician partners that are providing care within the JPS walls. So if you looked back at the payer mix, on this pie chart, it looks very similar to the pie chart from the medical center. It is pretty much the same patients. But in summary, we have about 46 open positions, 13 contracted physicians, and we are currently at $399 for employed physicians within a claim. Acclaim continues on their same trend that they've had this fiscal year. They did have a favorable month once again. You see overages for the net patient service revenue. You see overages in salaries, again, for some quality incentives, as well as those volumes that are coming through. And then they also had some expenses in purchase service. A lot of these purchase service overages are those contracted physicians that may have been budgeted to be employed, and we're just working on getting those contracts and recruitment. If you look year to date, Acclaim is about $1.7 million ahead of their plan. So both the hospital side as well as the physician side have had favorable years compared to our budget plan. Are there any questions on Acclaim? Okay. When you look at a consolidated statement, we do include our foundation. So you see, we've already covered the hospital and Acclaim. The foundation does have grant activity as well as fundraising activity that flows through. So for the month, you can see that we outperformed the overall budget by about $3.2 million. Circle the wrong number, I think. And then we also, from a net income standpoint, we are at $1.7 million for the combined. If you look at the year-to-date, you can see that that number is about $7.7 million total. I will say that this is an important slide. It does show us that as a combined entity, that we are operating at a profitable level. If you look at the budget number, which I cannot see on my screen, it's about $1 million loss that we had budgeted from a bottom line standpoint to this time. So again, we're doing great this year, mainly with the expense controls. Are there any questions?
No questions for Sharon? What if I don't want it?
Thank you.
Okay, thank you, Sharon. We will, I'll entertain a motion to accept the CFO's report. Motion by Mr. Fisher, second by Dr. Schrader. All in favor, please say aye. Opposed? Motion passes. Thank you, Sharon. All right, we'll move to item 6A. Oh, no, we already did 6A. And Wanda, item 6B. Good morning.
Good morning. I am here this morning to ask your approval for a sole source agreement between Smith and Nephew and the hospital district. This is for our leaf system that we have in the ICU. This is budgeted, and this is a program we put in place about 3 years ago. Actually, it's in 2015, so it's because it's been 4 years. So it's a sensor that you put on patients that detects as far as how you turn the patient, if you're getting adequate turning. We don't put these on every patient. We only put them on our high-risk patients, anybody that's going to be in the ICU for more than 48 hours, anybody that's going to be in a ventilator for more than 12 hours, and anybody with a Braden scale lower than 13. So this actually connects to a computer. The nurses can tell the level of turn for the patient to prevent pressure injuries. And since we've implemented this program, we've seen a 51% decrease in our pressure ulcers. So, and we have the highest adherence rate that the company's projected in the country at 94% of our nurses actually using the product and using it appropriately. So we're very proud of that. So this is for over the course of a 3-year term, so.
I will say that Wanda's innovation for this and her team of nurses that came up and did the pilot program and the study for this is pretty phenomenal, because Wanda was doing everything we could to minimize pressure ulcers. The problem is when you're moving a body in a bed, you don't know whether that's a 15-degree move or a 20-degree move, and you've got to get that body moved in such a way to relieve that pressure off that pressure sore, pressure ulcer. And that LEAF program is unbelievably phenomenal, and the nurses have done an incredible job. And the reason that I know is they let me go on, and when we did the pilot program, I was part of that, and it's just a wonderful program, and the team up there did a great job. So your nurses and you, for that innovation, have saved a whole lot of challenges to our patients.
Thank you, Rob. He made me a little nervous one day. He came in my office and said, "I'm going to the ICU to help turn a patient." And I'm like,
Uh-oh.
"Why?"
Right,
This is
right.
like a 500-pound patient. I'm like, okay. He makes me nervous when he does that.
Yeah.
Like goes into isolation rooms and goes
I
to turn
did get into
patients.
big trouble.
He wanted to see how it worked.
Yeah,
So,
yeah.
but that's great. So he got
I
to see
rounded
it
on an
firsthand.
isolation room, and I got in big trouble from Wanda. And let me tell you, you all get to see her like this. Don't go into an isolation room, because you'll see another side of her.
I need him for the long haul.
Great. Any questions for Wanda on this? Yes, sir.
You said that the number of pressure ulcers had decreased by a little over 50%. How about, what's the absolute number? How many?
When we started out, our baseline was about 45, and we're down to 22. And some of these patients are, they're there for a long time. They have, some of them are very heavy. Some of them have, lots of fluids and things that would put them at risk for developing a pressure ulcer. So we've made significant increases in that since then.
I can't remember, but is that a sentinel event type thing?
No.
Great. Okay, you've heard Wanda's explanation and the questions. I'll entertain a motion for,
Mr. Chairman, you got two components to this motion. One is the exception to bidding, and the other is approving the contract.
and we can do those in combination?
Yes, you can.
Okay.
I move that we accept to bid and approve the proposal.
We have a motion by Mr. Boza, second by Chairman Dow. All in favor of the motion, please say aye.
Aye.
Opposed? Motion passes. Thank you, Wanda.
Yes.
Pull item 6C from the agenda. I believe it's going to be in our board meeting next week, or whenever that is next week. But our CEO is going to give us a quick brief on it in closed session. Item D, Ms. Clark.
So Neil may want to introduce this policy for you guys, but this is kind of one of our, every so often, we do have to go in and revise the policy, make sure it's up to speed. So we've worked really hard on this
You know,
one
and
to
this,
make it
Sharon's
user-friendly.
office and my office, Amy Harris in her office, and John Lynch in mine, this has been a long-term work in progress. What this is to eliminate duplication. It pulled all of the purchasing components together under one procedure. They were in different places, very confusing in the contract process, and now they're all under one. There's nothing of substance that changed in here. It was a matter of pulling them together, eliminating duplication, and organizing them in such a fashion as to, when you begin the process, and flowing through that entire process to the end to ultimately get a contract. And so it flows well. I think Sharon and Amy have done a great job, and as general counsel, I would recommend your approval. Now, let me mention something here for the new members. As a board, you approve the policy, which is 7200. The procedures that go with a particular policy are here for your information. Obviously, if you have questions about the procedure, certainly ask, but you're actually voting on the approval of the policy. And this is going through the update process, as Sharon says, that ever so often we have to, under certain rules, we have to look at our policies and make sure they're compliant. Even if and many times we will look at them and suggest changes because there's law changes, and that particularly occurs at the end of a legislative session, which we will have here in June. So, but what's before you is the consideration of policy 7200.
I went through your procedure, and I didn't find but one actually change that was recommended in it. So I'm assuming that all the policies went over, and that was the only change that was made.
That is correct.
Just one little deal, okay. All right.
More of a consolidation than.
Well, yeah, and elimination of
consolidation.
duplication, yes,
Yeah,
exactly.
okay. Yeah. Move approval.
We have a motion by Ms. DeBose, second by Mr. Powell. All in favor of the motion, please say aye. Opposed? Motion passes. Thank you, Sharon. Thank you, Council.
Thank you.
Item 7 is a report from,
The only, Mr. Chairman, only comment I have under my report would be the monthly report that there were 36 contracts under $500,000 that were negotiated on behalf of the district. That list is posted on your web portal. If you got some questions, feel free to give Scott Rule or myself a call. 36. Okay.
Okay, great. Thank you. All right, we're going to adjourn for closed session for a couple of items. Appreciate everybody being here.